What does it really mean to support women with bipolarity, especially during pregnancy or after birth? Too often, these conversations are hidden, even though they are crucial for the recovery and stability. Welcome to Bipolar Talk, a podcast when we turn our bipolarity into an opportunity. I'm Clément Bessard, the founder of Upstage and also Bipolar Type 2. And today I'm joined by Dr. Fernanda Weyne, consultant psychiatrist, educator, and passionate advocate for women's mental health. She's also perinatal psychiatry and in trauma-informed care. And I'm just going to let you present yourself, Fernanda.
Thanks, Clement. Yes, my name is Fernanda. I'm a consultant psychiatrist. I work both in public and in private, and I am a very passionate advocate for best quality, best evidence care for everyone. I do have an interest in women's mental health, which is a new area of psychiatry, mostly because until the 90s, if you don't know, they didn't even do medication studies in women. Women were just treated as smaller men because it was just too hard. The truth is that as humans, we're all different, and there's a lot of nuance when it comes to women in particular, and the role that hormones and our status as women can have in the way that we display our distress and our emotions, and that we experience ill mental health ultimately. So thank you for having me.
I think it's really an important subject because there's on one thing, I think women are much more open about their emotion, which is a great strength when you have mental health and when you have bipolarity. And it's a big advantage. But on the other side, something that I can't really understand, there's also cycles, there's also pregnancy. So can you tell us a little bit what it changed?
Yeah. So I think it's important to acknowledge that, women throughout the centuries have received a number of, so people with ill mental health, but especially women, have received highly stigmatizing diagnosis for expressing their emotions. As you mentioned, women are more likely to internalize their feelings and then burst, with the tears or the irritability, whereas men, for some reason that we don't fully understand, often engage in those externalizing behaviors. That is not a rule because we're not, you know, robots. But in general, people do tend to experience distress differently. There's an influence of our gender that is not fully understood. And when it comes to pregnancy and all those moments in a woman's life in which there's a difference in their hormone levels, so, leading up to their periods, pregnancy, the postnatal, after they give birth, menopause, perimenopause, there is a higher vulnerability to experiencing ill mental health. Now, women can be different. So not everyone will be vulnerable to the same things at the same times. Some women don't feel these hormonal fluctuations the same way that others do. But in general, as a rule, we know that there's an increased prevalence of ill mental health in those moments of life. Now, depression and anxiety in the perinatal, they are highly prevalent. Psychosis is much more common than people think, but obviously it's considered rare. So when it comes to depression and anxiety, you have 1 in every 5, according to some statistics, 1 in every 4 women who will struggle with depression and anxiety in pregnancy. So the perinatal, sorry, I should preface this. The perinatal in Victoria is considered from conception to a year after birth, but we can hypothesize around pregnancy and giving birth, until that child is a little bit older. Whereas for psychosis, that prevalence is about 1 or 2, according to some statistics, but 1 in every 100 or every 1,000, sorry, which makes it much less prevalent. The problem is the psychosis, because it's rare and it tends to be identified maybe less than depression and anxiety, carries a much higher risk. And also, obviously, because of the nature of the symptoms. When you have a little tiny baby that needs to be nursed and held, we want women to be as well as they can in their mental health. There's a number of hypotheses for why that happens. We don't fully know yet. There's the sleep deprivation. There's a genetic vulnerability that some people might carry and others may not. There's the fact that labor is often very, very stressful. Pregnancy is very stressful, both from a metabolic perspective and from, pretty much all systems in your body get a bit overloaded with pregnancy. Um, there's the fact that, if people have a previous history of ill mental health, their medications tend to be a little bit more diluted in the third trimester. Obviously, the chances of someone having psychosis in the postnatal are much higher if someone has a history of psychosis. But lots of women don't, and we don't really know why. It's overall a matter of luck, having psychosis or not having psychosis. Now, this is not to terrify all women, but I guess the point is really to be able to have those conversations. So if people notice that there's something off, they can seek help. So the way that it happens is that usually the onset happens, in the first. So it happens quite soon after birth, in the first week, first month. Some people have it much later. Again, it's that art of psychiatry, that the rules not always apply. We know that as an entity, perinatal psychosis is very different to other psychosis that we have. It's quite close to bipolar illness. And in fact, when you see women that are manic, they more often present as manic rather than completely disorganized. And if it evolves, it tends to evolve into a bipolar illness rather than schizophrenia. But more often than not, just goes away with treatment. There's a huge risk, though, that you will return in subsequent pregnancies. So
Okay.
obviously, we are always very keen to intervene early, support women early, and prevent a relapse.
That's the goal. And you talk about something which is, I feel, really important. So we have this huge community with a few thousand people who are active every day. And one of the big questions is like, should I have children? And what am I going to do? Because it's kind of scary when you've been diagnosed as bipolar and you
Yeah,
know there's a genetic part, and you also know that it's going to be stressful for your body. So
yeah,
what's the conversation, and what would you advise when you have these people asking those questions?
yeah. So look, so we are very lucky that now there are genetic services that are available if people want to undertake genetic testing. Um, it's a new thing that we have in Australia and in Victoria. There's a public one, that obviously can be accessed if people need. It's mostly around big family history of heavy illnesses. Let's just put it like that. I think it's also important to keep in mind that when we talk about genetics, we talk about a vulnerability. We know that unfortunately there is, a history for families of carrying a gene for something, whether it is bipolar illness or schizophrenia or hypertension or diabetes or, problems with their thyroid or cancer. And obviously it is scary, but it's a risk. There are things that we can control, other things we cannot control. Having a bipolar illness can be incredibly burdensome, but it's not like people with bipolar are broken or they are wrong. They are amongst the most interesting and creative people that you'll see around. So it's really around, I guess putting on a scale the things that you might gain from a pregnancy with the risk, yes, of having a child that might experience ill mental health later in their lives and not having a child at all. I think it's also important to acknowledge that, there is a genetic component and I guess a higher risk of developing bipolar illness for people that have children, for people who have parents with a bipolar illness or a history of psychosis. It's also true that there are a number of factors in life that increase the risk. Trauma is one of them. Substance use is another one of them. Those are things that we can control. So, if someone is wanting to have a child, they have a history of major mental illness, they cannot change that history, but they can act upon all these other factors over here and, engage in strategies such as sleep preservation, having a good enough diet, having a good support system, having a good care team, having their medication optimized so they can have a pregnancy that is as healthy as possible. And anecdotally, lots of people with a history of mental illness do really well in pregnancy and the perinatal. It's really around all these other things that we are able to, put in our corner.
Yeah, and you explained it well. It's really about preparation. It's like it's gonna be an important period, and you explained that it's many trick. And there's something like I want to go a little bit deeper into is treatment because I feel like it's something like we hear it a lot, and it's like, oh, but maybe I have to change my treatment, maybe I have to stop my treatment. So same thing. Like, what is your point of view?
Yeah, there's a lot of fear of medications overall in pregnancy and the perinatal. There's a lot of fear overall of medications for most people, I guess. Um, it is true that most medications carry, again, a risk of side effects. Even Panadol, that people, take every day or often when they're sick and they're not too scared of. It's a risk. All right. Um, that's why we work with professionals that are able to support people in their journey and identify the medication that will best support them. For young women in fertile age, overall, we tend to avoid medications that have a known teratogenic effect, which is creating malformations. All right. We don't have heaps of studies in pregnancy because nobody does, deliberately studies in pregnancy. So a lot of the data that we have is retrospective. Um, we do know that as a rule, treated bipolar illness or treated psychosis has much, much better outcomes than untreated ones. And we know that by far and large, we have options of medications that are not associated with teratogenicity. There's a higher risk of other stuff, maybe, gaining more weight or having gestational diabetes, but not necessarily malformations. So obviously that's good news, but that's why you continue, if you want to have a child, you continue to engage with your psychiatrist, you continue to see, a good obstetrician or a good midwife, a care team that is able to support you in that journey. Sometimes doses have to be adjusted, higher, lower. Bodies change in pregnancy, and it's a huge preparation for fathers as well, because and for fathers, with a bipolar illness as well, because they also have to engage in all those things like sleep preservation, preparing for the huge adjustment that it is to become a parent. Um, I've been working in perinatal psychiatry for a long time, and I have to mention that I didn't understand fully how much lives changed once a child arrived until I became a parent myself. It's very other. It's not something that we are prepared for because suddenly everything revolves around that little person that for some reason refuses to sleep. So that's why it's so important to have a plan leading up to that so people can get there feeling ready to step up and do what they need to do, or take a step back if they feel like they're not coping. But again, overall, medications can be safe if they are prescribed mindfully by someone that knows what they're doing. It's always a risk benefit decision that we make together. We share the decision with the person. And we definitely don't make people take medication if they don't want to, but they have to be aware that obviously the risks of not taking any treatment increase exponentially during that stage of their lives for both men and women, but especially women.
Yeah, and I feel it's really like having those conversations with your psychiatrist because sometimes it's okay, like it happened to me. It's like I'm taking my treatment every day, but sometimes you're like, oh, maybe I can do it without it. And it's like
Yeah,
it happens. But
yeah,
it's like having the courage to have those conversations with your psychiatrist. It's like if you're thinking that you don't want to take treatment because you're having pregnancy, just say it. Explain why you're scared, and you'll always find a better outcome with someone who knows the drugs and who can even lower the dose. And at
yeah.
the end of the day, you are the one decided. And it's not your psychiatrist to decide for you. He's not going to force you to take the drugs every day. So no, but I think it's really important. We tend to be like sometimes idealizing a little bit psychiatrists, like to have the power. No, you have the power, but tell them that you don't want to. But as Fernanda explained, And I've seen it for like 99% of people who are like in good shape and stable. Yeah, we do take our treatment every day.
Yeah, that's right. But that's it. And just going back to what you were saying, it takes enormous courage. Both to accept that you have an illness and you need treatment and to be able to have those conversations. Nobody goes to people's houses and put medication in their mouths if they don't want to. Unless they need some sort of intervention that requires that. But that's really rare. Most people are like you and I, and they make choices. Um, but I think it's important, as you said, to have those conversations. That's the stuff that sets people up for better outcomes.
Yeah, and having this conversation also with people who live the same thing is like it's something that we couldn't have done because we didn't have the funding, but it's like having like talking group only with women. I think it would be really interesting. So I won't be there, but I think it could be because having some people live through the same thing and who has the same, yeah, I've had a child. This is how I handle it. And so it's like there's a lot of group, like Facebook group. We have one,
Yep.
but and that's it's having those conversations. So I wanted to go on something a bit more specific, which is breastfeeding
Yep.
and same thing treatment. So can you tell us a little bit about it?
Yeah. Look, it really depends on the treatment. And obviously, it's a decision that is made by the woman. We will never tell a woman what to do with her body and her baby. Um, if women want to breastfeed, we will work together to make sure that she's able to breastfeed. Um, Breastfeeding carries a risk of disrupting sleep. So often, if someone, let's say that someone is really vulnerable or they are really already struggling, um, what we would do is maybe try and make sure that they breastfeed during the day and then they can have a sleep at night and maybe the partner can come in and support them overnight or mom or whoever it is. You know, I think it's also important to acknowledge that A, every woman should be able to do what they believe is best for themselves and their babies. So breastfeeding is not a must, even though, obviously I know that there's a lot of buzz in social media around breastfeeding. If a woman decides the opposite, that they don't want to breastfeed, they are absolutely entitled to have their choice supported. Having said that, it's really the time to utilize those supports. We used to have babies in communities. The communities don't exist anymore because we're all isolated in big cities or, working and doing our own thing. So it's much rarer to see people that have a robust support of a community like they did centuries ago. Um, but overall, if there's a parent, if there's a partner, if there's a friend, that will be invaluable when it comes to breastfeeding. For lived experience, as you mentioned, um, there's a lot of groups that are available both in social media and through perinatal services because it's important to acknowledge that there's, again, a lot of stigma when it comes to ill mental health. But in the perinatal, because of the risks that exist for the families, the families and the babies that we see, the threshold for treatment tends to be much lower, which is not to say that we're going to medicate everyone all the time, but we tend to be quite cautious. And sometimes treatment can be engaging with a service and just finding someone to see the person regularly that addresses them to the right support in terms of exercise, diet, peers, the lived experience component that you mentioned, whether there is a health worker with lived experience or a mum's group, if it's for mums, or a father's group for dads, because that in itself can be incredibly empowering when it comes to making those decisions. Um, there are some medications that we don't utilize with breastfeeding. If the woman really wants to breastfeed, though, it can be timed, it can be changed. It's again about having a plan and discussing this plan together.
Yeah, and it's like we talk a little bit about that, and it's really like when things happened, which sadly, if you're bipolar, it something will happen at some point.
Mm,
Like it's the same for me. You have too much stress. You're not sleeping
yep.
well, so you need to prepare. You need to have a plan. It's like personally, for example, I have for some sleeping pills that I don't take often, but I have like melatonin, so easy peasy, and I don't do it that much, but I think it's like common thing. And then I have something stronger that was prescribed by my psychiatrist that I usually don't take much, but I know if there's like 2 nights in a row or 3 nights in a row where I couldn't sleep, then I take it. It's just like put me to sleep. I feel dizzy in the morning, but I'm prepared. I
Yeah.
know that it could happen. So I have my plan, and I advise you actually, if you haven't done it, is like to write your action plan. What happened? What do you do? What are your triggers for? Could be manic phase, could be depression phase. I'll
Hmm.
put the link into the description. Curious to have your advice also. I'm always trying to improve them, but it's really like just a small form that you can write, and it's really like, okay, do I talk to when it happened? Uh, what are my triggers, and what do I do when it happens? Because at the beginning of a phase, at least for me, because I'm bipolar type 2, there's things I can do sometimes to prevent it, or at least to reduce the length and the strength. So
Yeah.
I think it's even more important, as you explained, Fernanda, into like preparation of like becoming a mother or even a dad also on the other side.
Yeah. That's absolutely right. So that's usually what we call, with the beautiful word, safety planning. Um, Part of the safety plan for new parents, and especially new parents who have a history of mental health, um, involves sleep conservation. So getting as much sleep as they can leading up to the baby arriving, engaging with supports. So supports both in the family and outside of their family. That includes services. There's heaps of perinatal services available, in Victoria and in Australia. We're very lucky. Um, having a good care team, engaging in a birthing plan can also be really positive, and putting it in writing, as you mentioned. Not always it's possible to follow that plan to the T. And obviously, the birthing plan of someone with a mental illness can look a little bit different to the plan of someone who doesn't have a mental illness. Often women get a bit carried away and they think about the music that they want to hear or the candles that they want to have, which can be really tricky, especially if they are arriving in hospital, already in labor. Um, but if you have a mental illness, it can be, how do I feel safer? Am I safer with less noise and less light? Do I like the light? Do I want the noise? What does that mean for me? Does that make me feel overwhelmed? Does that make me feel, um, yeah, so thinking about all that in advance and having a conversation with your care team and putting it in writing can be really empowering. Um, some people like to have an appointment with an OT, an occupational therapist, and do a sensory profiling to understand how their bodies react to different stimuli. That can also be good if it's their thing, or, if they like meditation or grounding exercises, that can be really good. Delivery in itself is very stressful. Disclosing which medications you're taking and the doses is obviously powerful in terms of allowing the team to make choices that are appropriate for that person. As you said, if you have a medication that you can use, if you feel overwhelmed, it's important for them to know, rather than, having people scrambling and giving you stuff they've never tried. Um, if having your partner there is a support, have your partner there. If you prefer to have someone else. So all these things, when thought in advance, they reduce the rates of distress and birth trauma, but also set people up for much better outcomes. We see quite often women that for some reason had a really bad experience in their first birth, had a psychosis. Maybe they had a psychosis which evolved in a bipolar illness. Maybe they're still finding their way back to feeling like themselves. All these strategies that empower people and allow them to be in the driver's seat when it comes to their birthing experience, their pregnancy, and their postnatal, um, often are associated with much better outcomes. And we did see people as well over the years that for some reason, had a really bad experience, really negative outcome. And then with that little bit of medication that you mentioned, those conversations about triggers and early warning signs were able to mitigate those risks and maybe not have a psychosis when they have a second child or a third child. So again, I just want people to be aware that there's no rule. and people have an active role in deciding what is best for them. As health workers, our role is to support and guide people, not tell people what to do most times.
Quick break. Can you let us a review on Apple Podcasts or the platform of your choice? It really helps us break the stigma around bipolarity. Let's get back to the episode.
Yeah, and it's the beauty of how psychiatry is changing. It's like,
Yeah.
at least for most of the psychiatrists I talk to, is like, you really see this like mentality. But I think I'm biased because the fact that you're doing a podcast with someone who has bipolar, it means you're already open-minded. So, but
Yeah, maybe, but it's also a trend. We talk a lot about lived experience. We talk, and again, even among psychiatrists, there's so much stigma around mental health. We're all human. Ultimately, we're all here for the same reason. We want to feel well. We want to help other people feel well. That idea of, the psychiatrist or the doctor up here as this sort of untouchable thing, and everyone else here having to obey and serve is outdated. It's not how we do mental health nowadays. So it's a good thing that it's changing. It's a good thing that, we have a college who is supportive of this change. We have new people coming in, bringing new perspectives. We have more and more diversity. I come from overseas as much as you do. We have First Nation psychiatrists. So it's a really exciting time.
yeah, no, I do agree. I want to go back because we talk a lot about before the pregnancy, about preparing, but then there's the after. And it's nice you've prepared, but then everything goes the way it will go because nobody knows. And you explain to us, Fernanda, that is also this period of possibility like depression, but even 1 year after. So
Yeah.
why is it happening? And what can be done by the person concerned to maybe try to prevent some of those?
Yeah. Why is it happening? We don't know. There's a number of different theories. So there are some theories that say that people experience elevations or depression in their mood, or changes in their mental state because of the hormones. They go up, they go down, they crash, they rise, they do a bit of everything um, during pregnancy. And while women are breastfeeding, that is still a very unique status that their hormones will have. Um, some people, for example, they experience feeling foggy in their minds, or, if they have a history of ADHD, sometimes it sort of comes out right then and there because there's an interaction between feminine hormones and brain function. We don't know the full extent of it, but we do know, for example, that your estrogen, that tends to be neuroprotective, that interacts with your dopamine levels, is going to be decreased when you're pregnant. And it's very tricky when it comes to understanding exactly why it happens. There are some hypotheses that speak about um, an autoimmune component or an inflammatory component when it comes to psychosis. So we don't know why it happens. Again, it's a matter of luck and vulnerability. We know that someone that has a family history, so a mom who had a history of depression or perinatal depression, especially, or a sister, or someone conversely that has a history of psychosis, they are more likely to experience that. So there are a number of options available if people are struggling after birth. Um, there's a lot of public perinatal services available that people can contact, both for more robust support or support over the phone. There's Panda, there's, Beyond Blue. So there are different things that people can access, and they might help address them to the right type of supports. There are parent-infant units that we have nowadays that allow parents, if they need a hospital admission, to be admitted with their babies, which is huge because, that's new. In the olden days, mums would be separated from their babies, which obviously creates all sorts of trauma and distress for both parties, both mom and baby. There are providers in the community who are able to step in and support women and men if they are struggling with ill mental health, because that's something else that I should have mentioned, but I didn't. It is so statistics suggest that it is a stressful time also for fathers. There's an element of adjustment that affects both men and women, in how their role changes, their, sense of self changes, and the prevalences vary, but, around 30% of the male partners of females struggling with perinatal depression, for example, might have a problem with adjustment themselves. So that's huge. That's heaps of people. Um, so again, it's really understanding what is the support that that person needs. Overall support goes through talking about what's happening and disclosing the thoughts, because that's the thing about mood episodes, as you know, and other people with a history of depression or bipolar illness know, the way that we feel affects the way that we relate to ourselves and the world. And that inevitably changes the way that we think. So, it's quite common for women to have really scary, terrifying negative thoughts, both about themselves and sometimes their babies. Sometimes just talking about that makes it less real. Perinatal services are very good at supporting women in that phase. Maternal child health nurses are available as well, sometimes as a first stop. Mental health triage lines available. But again, overall, talking about the problem and engaging with supports, engaging with sleep. Medication can be really powerful when it comes to engaging with sleep. Um, Having movement in parenting is also very important. So it's that rupture and repair. Having the baby while the parent is able to care for the baby, handing over the baby when the parent is not able to look after the baby because they need to look after themselves. And it's a bit when the airplane is falling. You will put your oxygen mask first, because if you're unwell, you're unable to help anyone. And it's a bit the same. Obviously, biologically, women, because we are talking about women are activated to have a response to babies who are crying, and sometimes it can be incredibly distressing and anxiety provoking to have to hand over a crying baby. But if you're not able to do that, it's much better for you and for the baby for you to take a step back rather than insist in something that might not be going that well for the both of you. But obviously, it's hard to generalize. Most women um, are able to, because women are pretty amazing at that. Women are often able to be excellent for everybody else in the family, and sometimes struggle with those negative thoughts and feelings without showing it overtly to anyone else. That is a bigger concern. That is a bigger concern, because obviously we know that not talking about stuff just makes it harder.
But on the opposite side, it's really interesting because about 75% of our audience are women. And same thing on almost every platform. Without YouTube is a bit different, but like 50-50 a bit. Like on the community and on talking group, I think it's even higher. And so we see that women are more like accepting, I would say, like taking the thing and like, oh, I need to talk about it. I need to learn it. Where men sometimes are a bit like hiding it under the carpet, like, oh yeah, I don't know, it's gonna be fine. But so talking a little bit about men, because I think it's really, as you explained, a partnership about like how the team are going to handle both things. So I'm trying to do an episode more for women, but so
Hmm.
how can she talk to her or his partner to really like, okay, I'm having like bipolar or even not, like I had a depression or I had some family who had. So I'm trying to prepare and I want to do the best thing as possible about my sleep because as you explain, is like, so how the partner and how to have those conversations so it can work as best as possible.
Yeah, that's a really great question. So ideally, we would set the foundations before the pregnancy, and people would be able to feel safe in their relationship to have those difficult conversations. It's not always the case. Um, as much as possible, perinatal care involves the partner. So even when making decisions about medications, it's important for partners to be involved. When it comes to, men struggling with their mental health, for example, that is often in the context of men not having much that is allowed to them when a new baby arrives because mom is doing everything. So, sometimes it's about negotiating things that can be shared, if, especially if the father wants to be present, which most fathers do. It can be the the father has bath time or the father has feeding time with a bottle once a day. So mom can go to sleep, which usually works really well for women with a bipolar illness because dad might be in charge of some feeds. It's about negotiating those things early enough and utilizing your psychiatrist or your healthcare provider, whoever they are, to have those difficult conversations together. Um, it can be blindsiding for a partner to have someone becoming unwell, never having told them that they, had a history if that was the case, or just to see your partner becoming unwell for the first time. It's really confronting and terrifying. So, as much as possible, being a team and keeping everyone informed of what the plan is, keeping everyone informed of what the risks are, even before things happen, is the best way to go. Um, your mental health provider can help facilitate those conversations. The problem is when there is an unsafe relationship to start with, and there's blaming or there's shaming or there's lack of support, that is when it's hard. Most times in healthy relationships, the problem is around the person with a history of ill mental health experiencing guilt and shame. But in that case, I would say, if you have a good partner and you're intending to spend time with that person, you really want that person to know you and to be able to support you. It's also about giving people a chance to be their best selves when you speak up about that kind of stuff.
Yeah, and it takes strength to talk about this subject because it's like, of course, you want to be like, so I'm talking it from the men's side, but it's like having this conversation with your partner. Like, I have some family, and you, and it's always like scary, and you're like, oh, but the person is not gonna love me or this type of thing, and but they usually love you more because you share something really great, and they're like, oh, so the person really loves me because they trust me, and it's
Yeah.
usually the opposite that happened.
Yeah. I think that the another issue to keep in mind is that there's an element of how society makes women believe they should be behaving in their pregnancy or parenting that is detached from the reality of pregnancy and parenting, especially now with social media. Um, when I see my clients, we often talk about the fact that, women struggle for a number of reasons. Obviously, there's no one fact. Um, but we do live in a world that, you know, pushes women to be always perfect at everything and look a certain way and behave a certain way. And then you have those influencers. I mean, I'm not on social media, but you do have a lot of mums running on the beach with all these beautiful children, all 6 months apart, all dressed in white, you know. So it's a pretty big issue because women end up carrying shame for things that are normal and they're not their fault. Parenting is really hard. Now, I'm wearing out white today. People cannot see me, but I am because I don't have any kids around. And I do this for a living. It is hard. It is really hard. And, your body changes, your sleep changes, everything changes, but it's like putting your body through war. Now, you wouldn't ask of someone with a broken leg to get up and run a marathon. Why do you expect a woman that, has a little child and is doing everything to keep things going, to just be perfect at everything and be fine with their mental health and not struggle at all? Sometimes just having these conversations, again, um, allows partners to support their partners and babies. Most people are in it for the right reasons.
Yeah, no, no, but I totally feel what you're saying because is like even more, I would say, when you're bipolar, is like we are different, and some stuff are tough, and some moment is like we cannot even do like we're even more different, and we cannot even rely on social media as much. It's like,
Yeah.
so it's been about like, yeah, it's not us. We're not the typical like mom, father, whatever.
Yeah.
And it's, yeah, it's about acceptance. And
Yeah.
we will have probably a different experience. It's going to be a great experience. Everything's going to be fine, but maybe we need more help at some point.
Yeah.
Maybe, but I haven't been a dad. I wish I will be, but it's like, yeah. So, if you have a magic wand,
Mm.
what would you change in mental health?
In mental health, so many things. I In mental health, I probably would change um, the fact that some people don't understand that when we talk about behavior, when we talk about diagnostic entities, we can be seeing the exact same behavior in different issues. It's about engaging with the person and formulating a diagnosis that makes sense to that person, not to themselves. So I would probably change the amount of knowledge and the amount of investment that we get in some areas that have traditionally been overlooked, and women's mental health is one of them. Um, when it comes to society, I would probably increase awareness and allow people to understand that we are all different, and there's also beauty in that difference. Um, most people are not that perfect image. There might be one person for millions that are not. So why do we keep looking at that as a point of reference? And that's why it's important to have those conversations, because if people are not alone, even though it feels that way.
Thanks a lot for your time, Fernanda.
Thank you for meeting with me today, Clement. It was lovely.
Yeah, it was fun. If you still have 2 minutes, and you can say yes or no, but I try to do this kind of like quick question that you have to answer really
Okay.
quickly. So if you can, it's okay. Or it's like I'm starting this since like a few weeks, so it's a bit new
Yeah,
for
no,
me
that's
too.
okay. I talk a lot. That's the problem. But yeah, happy to
No,
try.
no, no. It's why I love podcast. It's like you have the time. It's not like you know what I mean.
Yeah, I do.
Um, should every maternity ward should have a perinatal psychiatrist?
No, but they should be engaging with perinatal services for
Mm.
sure. They should have a good relationship with their perinatal service. We have heaps of good clinicians. So, not necessarily a psychiatrist, but definitely someone that understands what happens and can call a psychiatrist.
Can trauma be passed from mother to baby?
Um, not, not, not necessarily. Yes and no. We do know that trauma happens in families. There's intergenerational trauma. We don't know if it's because of trauma leaving an imprint or because, unfortunately, trauma tends to repeat itself. So, yes and no for that one. That needs a whole different podcast.
Are women still underdiagnosed with bipolarity?
Um, yes. Yes, especially type 2. Especially
Eh,
now that there's so many, other diagnoses like borderline personality disorder, complex PTSD, um, ADHD that can overlap.
Can birth itself can be traumatic even without complication?
Yes, 100%.
Do most partners underestimate how fragile the postnatal period can be?
Yes.
Okay. Is full recovery possible after severe postpartum psychosis?
Yes.
That's a good sign. um, can motherhood make bipolarity more visible, not worse?
Motherhood.
Yeah.
Yes. There's a much higher chance of having episodes in pregnancy and the postnatal. So yes, unfortunately.
To learn more about bipolarity, go to our website upstage.com, HOPESTAGE.com. See you soon.